Intraosseous access can be used in emergency situations when alternative access proves difficult.
Once in place, IO access lines may be used for administration of medications, fluids, and blood products. Physicians must thus be familiar with the safe and effective insertion of IO lines. This module will serve to demonstrate the skills necessary for proper placement of an intraosseous line. Indications for placement of an interosseous line include need for administration of life-saving medications, fluids, and/or blood products, as well as inability to obtain alternative IV access. Contraindications include fractures, deformities, or hardware placement proximal to or involving the insertion site, as well as need to place line through a site of infection or gross contamination. Additional contraindications include severe peripheral vascular disease as well as osteogenesis imperfecta. We will now discuss equipment necessary for the placement of an interosseous line. When time allows, sterile techniques should be observed, including a sterile hat, mask, gloves, as well as towels, gown, and the area should be prepped with chlorhexidine solution. The interosseous needle driver kit comes equipped with needle driver itself, as well as connection tubing and needle safety device. Separate needle will be allowed for attachment depending on size needed. Once in place, the interosseous line can be connected to fluid using interosseous tubing, sterile saline solution, as well as saline tubing. We will now discuss relevant landmarks for placement of an interosseous line. For placement in the tibia, first the patella should be palpated and the tibial tuberosity inferiorly, 1 to 3 centimeters inferiorly, and 1 centimeter medially to insertion, placed at a 90-degree angle. For femoral placement, lateral condyle of the femur should be palpated, and then 3 centimeters proximally at a 90-degree angle placed into the femur. For placement in the arm, the lateral condyle should be identified and the anterior surface of the humerus should be palpated until the greater tuberosity is identified. Palpate along to the inferior border of the greater tuberosity and place interosseous line at a 90-degree angle. If time allows, the area of insertion should be draped with blue towels and areas should be prepped thoroughly with sterile solution. Needle size should then be chosen. Package opened. Package will come with interosseous tubing that can be removed and placed to the side, as well as interosseous needle. First, remove the protective cap and then connect needle to interosseous needle driver. The needle should slide easily into needle driver and lock when secure in place. Needle driver should then be grasped firmly and placed at a 90-degree angle to the correct anatomic landmark. Steady downward pressure should be applied until needle is in place. Needle driver and inner needle can then be removed at that time. After the interosseous line is in place, the needle should be protected and line connected to interosseous tubing and then connected to IV fluids. Confirmation of placement is found when IV fluids are found to drip freely. In order to remove an interosseous line, it should first be disconnected from IV fluids. A twisting upward motion should then be repeated until line is freed from inner cortex and skin.